And we're starting with just a little bit of refresher on the kidney. So, basically you have the kidney. It has this large artery that's bringing that blood in. And then there's little blood vessels that are going to branch off, and those are going to go to the nephron. And then that nephron is where the work of the kidney is going to take place. So all those things like glucose, salts, amino acids, urea, they're pushed out of the blood vessels and into those nephrons. Okay. And as they go through the nephrons will determine, what's going to go back into the blood and what needs to be removed. All right. And whatever it determines does not need to go back into blood is waste, and that's going to go back out. Once it's cleaned, it'll have a little bit less water and a little bit less waste material. Okay. And that'll leave the kidneys and go back into a large vein and back into the body. It'll end up as urine, which is typically yellow, and it's supposed to leave the kidneys through the ureters and go into the bladder. It's stored there until that little mixturation process takes place with mostly a reflex. So as your bladder fills up, that reflex will help it release and expel that urine out. So you kind of got to know how the blood flows through there, because that affects your glomerular filtration rate. You don't need to know everything on this slide, but you need to know the basic things. Like, it's coming from an afferent arteriole. Those are incoming. So they're coming into the nephron and into that glomerulus. And when it leaves the nephron, it's going to go to the outcoming, or the efferent arteriole. And then eventually they'll end up in these peritubular capillaries. These are just the ones that go around the kidney, okay? And the vasa recta, which is going to carry it over to the vein, that renal vein, so that it can go out of the body, out of the kidney and back into circulation. So it goes into that renal vein. Eventually, it'll end up in the inferior vena cava, okay, and back into circulation. So you have that renal artery. That's the main artery entering that kidney. And again, it's going to form the afferent arteriole that supplies the nephron. So that's the incoming arteries. Now, remember, what doesn't go in there is protein and red blood cells, because they're too big. All right. So those are going to bypass that and go on into the basement membrane. The afferent arteriole is going to bring the blood to the glomerulus, and in that area is where it's going to be filtered, and then it goes back into the efferent arteriole, and eventually it'll end up in that renal vein and to the inferior vena cava and back into circulation. Or it becomes waste and it goes out of the body. All right. And this is just talking about the other half of that process, where I said once it's filtered, it's going to go into the efferent arteriole, into the peritubular capillaries. And it just tells you here, this just means it goes around the kidney, around the system. Okay. And then it joins up with the drain that drains that renal vein. Okay. And takes it back into circulation. So a few processes that help that urine form. You have the glomerular filtration, you have reabsorption, and you have secretion. And it says tubular because that's really where it happens, in those tubules. All right. So filtration is where it's removing, okay, things from the blood, and then it'll reabsorb the substances that it needs, and then it'll excrete the waste, or it'll put it back into the vein to go back into the system for circulation. So in those tubules, you have reabsorption of your nutrients, your water, your electrolytes, and secretion. Also, there are hormones that are going to control the reabsorption of fluid and electrolytes. So those main ones that we talk about are ADH, aldosterone. We also talk about renin. And another one that I'm going to talk a little bit about in a few minutes is the parathyroid hormone, because that also helps with a couple of things. So the reabsorption process, that's removing the solutes and the water from the fluid, okay, and returning back to the blood. So a lot of the water, the ions, and the nutrients will be returned back into circulation here. And then secretion is moving the solutes from the blood and the nephron cells into that tubular fluid, and that removes the substances that are not filtered. And this is just like a fine tuning of the urine here. All right. So the major function of the tubules is the reabsorption process. That can be either through active or passive transport. Also, secretion by the tubules help the urine formation without affecting the electrolyte balance. During filtration, we'll have a large volume of fluid, including the waste, the nutrients, the electrolytes, those other substances that are dissolved there, and they'll pass from the blood into those tubules. Remember that cells and protein, red blood cells and protein, remain in the blood. They don't go through that process unless the kidney's damaged. And if it is, you'll know because you'll have protein or blood in your urine. When the filtration pressure increases, more filtrate forms and more urine is produced. All right, so this is I just try to break it down for you as simple as possible because this could be a little bit of a complex subject here. What do you mainly need to know? What is that kidney doing? Okay, so here's your little components here in the nephron. So if you're not sure, it just kind of gives you a basic layout there. All right, so the glomerulus is getting rid of or filtering those solutes that are in the blood. The proximal convoluted tubule, that's helping you to reabsorb those electrolytes, the water, the nutrients. It's also helping adjust the pH, getting rid of toxins. The Lupa Henley, this is where your diuretics like furosemide, they work in here. Okay, so this allows water to move from the filtrate into the interstitial fluid here. And then 5 is your distal convoluted tubule. That's secreting and absorbing different ions to maintain the blood pH and electrolyte balance. Your collecting ducts, which is reabsorbing the solutes and the water from the filtrate. All right, so all those are just part of that function of how those kidneys work. You have millions and millions of those little nephrons in there. So it's not like one little nephron doing all this work. There's millions of them in there. And inside each one of those nephrons, this process is happening. And this is going to maintain your blood volume, your blood pressure, your osmolarity. Because why your osmolarity? Because again, that's the saltiness of your blood. Okay, so if your ADH is helping control that, then if you're too salty, it's going to help you hold on to some more water. If you're not salty enough, then it might stop producing and let you release some more water. And then this whole system, okay, is regulated by the neuroendocrine system and by hormones like ADH or antidiuretic hormone, aldosterone, and the parathyroid hormone. Now, over here on the right of this slide is just trying to show you the process, okay? At the top, you see you have that large kidney artery coming in. Then the blood is going to go into the afferent arteriole, right into the glomerulus. Once it's filtered there, it'll go to the efferent area and then out, okay, to wherever it needs to go into that renal vein for circulation. Any questions on any of that?
No.
All right. So once again, this is just showing you how that nephron is working. What's it doing? And it has two compartments. It has a vascular compartment. It has a tubular component. They're all located in the cortex. Okay. And they're the primary workhorse for those kidneys. So if you look at all the little steps here, and we just talked about all these, I'm not going to go through them again. But if you go through these, it just shows you each step of that process, what it does in each one of those steps. So you know what's happening where in the body. Trying to move my Zoom screen and it switched my slide. All right, so now you can see all those components. How does it work? What do they do? Broken down. I showed them to you broken down. Now you can see them together as parts. All right, now let's look deeper in there. So that Bowman's capsule, okay, that's also known as the area where your glomerulus is. The glomerulus gets the blood supply from that afferent arteriole, and the fluid and the solutes are going to be filtered out during filtration. A lot of that fluid, the waste, the nutrients, the electrolytes, the dissolved substances all go from the blood into the tubules. The cells, red blood cells specifically, and the protein stay in the blood, and they're not filtered unless there's damage. Okay, so if there's damage to the kidneys, then we might find blood and albumin in the kidneys. If the blood sugar is out of control, we'll find sugar in there. If someone's using fat for energy instead of insulin and glucose, then they're going to have ketones in their urine. So all these things can tell us what's going on in the body. There are other things the body can produce too, like when there's damage to the kidneys from protein and stuff like that, you'll see other things produced in the urine as well. Also, the urine can be indicative of some sort of damage from like hepatitis, because it could be like a brown, black color. You can develop viral hepatitis that could cause that. You could also have a drug-induced hepatitis that could cause that. All right, so what is that glomerulus? It's really this large surface area of capillaries. And this is where the liquid is filtered from the blood under pressure. That's where that filtration process has. And then the filtrate will produce water, glucose, salts, and urea. And I know I keep saying it over and over, but the protein and the red blood cells are not going to pass through there because they're too big. All right, let's talk about some of those hormones. So we've talked about them before. Maybe this little diagram will help you over here, okay? When you have too much fluid in the body, if you look on the top row of the diagram, okay, less ADH would be released and less water reabsorbed and more urine put out because you have too much fluid. So you don't need more fluid. But when you're dehydrated or your fluid's low or your blood pressure's low, then your water content is going to be low. So your body's going to release more ADH, more water is absorbed, and less urine goes out. Antidiuretic hormone controls the amount of fluid leaving the body. We're talking about water only. And it does that in the urine. It also can promote reabsorption of water back into the blood if the blood water content is too low. And again, that happens in the tubules of the kidneys. Okay. All that is happening in those tubules. So ADH can actually work in that loop of Henle or that proximal tubule. And this can be affected when someone takes a diuretic like furosemide, okay, to help them release more water. Because when we give somebody furosemide, they have too much water. All right, so ADH is going to stimulate water retention. If it's released, it'll cause the kidneys to retain water. And if it's withheld, or if it's not produced, or if it's inhibited, it'll cause the kidneys to release water. Okay, we got that? Everybody got that? Any questions on that? This is also known as something called vasopressin. Come on. All right, aldosterone is the next one. This regulates the sodium and the water balance. Okay. So it's secreted by the adrenal cortex. The action of it is to increase the retention of sodium and water through reabsorption and increase the excretion of potassium by the kidneys. It also helps conserve fluid whenever there's a fluid deficit in the body. It will also be inhibited, okay, if we have fluid volume overload. So if there is too much fluid going back to the heart, what is the heart going to release? Talk to me so I know you know. Too much fluid coming back. What's the heart going to release? It's going to stretch, and that snitch bitch is going to come out. What is it?
AMP.
AMP.
Okay, AMP. And AMP is going to go to the kidneys and tell the kidneys to stop producing aldosterone, stop producing renin. And that's how the body prevents salt induced hypertension. When that extra volume comes back, it's going to cause the heart to release what?
AMP.
AMP.
And that's going to allow it to inhibit
The sodium in the water.
through
Well,
the
more the fluid.
inhibition of aldosterone
Oh.
and renin. Okay. All right. So aldosterone is closely linked to the renin and the angiotensinogen, and it's part of the renin angiotensinogen aldosterone system. They work together typically. All right. So usually this is just regulating your blood pressure on a normal basis. Okay. Blood pressure goes a little bit high. The AMP will come out, run down to the kidneys, tell the kidneys, hey, slow down a little bit, bro. We're good up here. If we don't have enough flow, it's also going to trigger low flow into the kidneys. And when we have low flow in the kidneys, it releases renin. Renin goes to I think it goes to the lungs first and then the liver. But at any rate, it's going to be converted into angiotensinogen 2, a vasoconstrictor. Okay. So we got low flow. Now we need vasoconstriction and we need more sodium and water. So we're going to release aldosterone, release renin, bring the blood pressure up now. Okay. So blood pressure is too high, volume's too high. AMP will cause the kidneys to inhibit renin and aldosterone. Blood flow into the kidneys is low. That will trigger the kidneys to release renin and aldosterone to bring the blood pressure up. Got it?
Yes.
Okay, so renin is an enzyme. It's put into the blood and it's sensitive to changes in the blood flow and the blood pressure. So whenever the blood flow in the kidney is low, it's going to talk to the renin. Whenever the blood flow into the kidneys is too high, it's going to talk to the renin. Okay. Where does the signal come from? So if it's coming in low, that's a natural process of homeostasis for the kidneys and the renin. If it's coming in high, that AMP will trigger it because too much fluid coming back in the heart. So the renin recognizes that we have a change here. All right. The primary stimulus for increased renin secretion is decreased blood flow into those kidneys. And this could be caused by like diarrhea, where you're losing sodium and water, persistent vomiting, excessive perspiration, renal stenosis, where you have narrowing of the renal artery because of diabetes or high blood pressure damage. So we produce renin, Okay. When we produce renin, that's going to help us hold on to salt and hold on to water. It also helps convert vitamin D along with the parathyroid gland. Any questions on renin? Okay, your parathyroid gland. And this can be damaged when someone has their thyroid taken out. Okay. This is typically when this gets damaged because it's really small. It's right next to the thyroid gland and it's easy to be nicked. All right. So it releases the parathyroid hormone whenever the body detects that you don't have enough calcium. It controls phosphorus and vitamin D levels, and it regulates the calcium level. And that makes sense because what's the story with calcium and phosphorus? Anybody know? So how many of you do dialysis? Anybody ever
I was
done
about to say I
dialysis?
don't know the story, but I know they go together.
Okay, so like when someone's on dialysis and we give them phosphate binders because we don't want that phosphate to go up too high. So we give them binders to remove the phosphorus from the body. The calcium goes up. So they have an inverse relationship. As phosphorus goes down, calcium goes up. As phosphorus goes up, calcium goes down.
This one is this called antagonist
I'm
reaction
sorry?
or something like that? Is this like antagonist reaction or something like that?
I didn't understand.
Antagonist reaction. Is this the phosphorus calcium?
This is I'm talking about parathyroid hormone and the
Mm-hmm.
phosphorus and calcium inverse
Calcium.
relationship. So I'm talking about how the parathyroid controls both the phosphorus and the calcium level in the body and just trying to relate the reason why. Because
Okay.
if the parathyroid gland were to elevate the calcium or try to, bring up the calcium level, what would happen to the phosphorus? If they have an inverse relationship,
Won't go
Inverse.
down.
it's going to go
Yeah,
down.
Go
right.
down.
Okay. So
That's what
as
I
one
thought.
goes up, one
One
goes
go
down.
down.
All right. Also, parathyroid triggers the release of small amount of calcium from the bones into the bloodstream. It helps with the production and activation of vitamin D in the kidneys. It signals the kidneys to keep calcium in your body rather than excrete it. And it does that during the filtration process. And it also helps the small intestines absorb more calcium from the food when it's necessary. So whenever you have a kidney problem, it can affect your parathyroid gland. Okay, can affect your ability for the vitamin D, for the control of the phosphorus and the calcium. I don't know what happened here. Um, I don't know why that parathyroid thing's on there, but let's look at HL natriuretic peptide. Okay, this is going to reduce the sodium by decreasing the blood volume, lowering the blood pressure, because when the heart releases too much fluid, it stretches, A and P comes out. It's going to go to the kidneys. It's going to inhibit the renin. It's going to inhibit the aldosterone. And therefore, that is going to decrease the sodium level. That is going to decrease the blood volume. And that is going to lower the blood pressure. Okay, so that's what you really need to know about it. For the glomerular filtration rate, there are three forces involved in it: the glomerular pressure itself, the colloid pressure, and the hydrostatic pressure in the Bowman's capsule. So, all these, whenever they're affected, they can affect your glomerular filtration rate. in the body, we have something called autoregulation. I'll try to explain this a little bit more in a second, but there are local adjustments that are made in the diameter of your arterioles, and this is made in response to changes in the blood flow in the kidneys. So again, that has to do with your renin, angiotensin, aldosterone system, because whenever the kidneys recognize changes in flow coming into it, it's going to adjust in some way. All right, your sympathetic nervous system, which is going to increase vasoconstriction in both arterioles whenever you're stressed, whenever your fight or flight kicks in. Okay, we're going to see vasoconstriction there. And then renin, which is secreted whenever we have low blood flow coming into the kidneys. So remember, I said that that blood flow comes in from that renal artery, and then it goes right into that afferent arterial. So if the blood flow coming into the kidney is low, it's going to be low going into that afferent arterial as well. And that is going to cause the kidneys to secrete renin, right? Because we have low blood flow coming into the kidney. So it sounds complicated, really not. If you just think about how that simplicity is of how those arteries come in, then you can see why this is happening. The body's just trying to maintain here. If your GFR is too high, then the substances that were supposed to be reabsorbing won't be able to be reabsorbed, and they'll be pushed out into the urine. So that's a problem. We don't want it to be too high. Okay. If it's too low, then everything is reabsorbed, including wastes, and that can cause a problem with us as well. So normally when would you see low is either dehydration, um, shock, kidney failure. So usually your body's just normally controlling all of this by controlling your blood pressure. And it's doing that through, those neuro controls we've been talking about, those hormones we've been talking about, and through autoregulation. All right. So everything that really we've already been talking about. It's just fancy words for it. So whenever we have vasoconstriction or dilation of the afferent arterioles, it's going to affect the rate of the flow. And that's because, again, the blood's coming from the renal artery and going right into that afferent arteriole. So that's going to affect how the blood leaves out of there and goes into the glomerulus where that work really happens. And so that can affect your glomerular filtration rate. And that's really just the rate that the kidneys are going through and reabsorbing and filtering everything out in a 1 minute period. So things that are going to help regulate that GFR are your sympathetic nervous system, the autoregulation, and any changes in the diameter, okay, that happen from either some sort of extrinsic or intrinsic mechanism. What does that mean? So anything that causes a change in the vessel there, low blood flow coming in, too much blood flow coming in. So when would we see that? Like diabetes, hypertension, kidney failure, or something that's maybe obstructing the flow there for some reason, like a kidney stone or a tumor. All right, so atrial natriuretic peptide. Again, this is going to help with whenever the blood pressure is too high, it's going to help bring it down. All right, by stimulating that, by inhibiting that aldosterone and that renin. Okay, we go with that part. And this slide here is just showing you how, again, when the blood flow is coming through there. Okay. If we have vasoconstriction, that's going to decrease our blood flow. If it's in the afferent, since that's bringing the blood into the glomerulus, is going to decrease your glomerular filtration rate. If we have vasodilation in the afferent artery or arterial, then it's going to increase the blood flow there. And that can increase the glomerular filtration rate. What kind of things would cause the glomerular filtration rate to decrease? So let's look at them. All right, kidney disease, diabetes mellitus, and hypertension. Why diabetes mellitus and hypertension? Because it can damage the vessels coming in there. Urinary tract obstruction. Decreased renal flow because of an increase in proteins. So kidney not working, some other issue going on there. All right, a decrease in angiotensin too. So maybe we're giving somebody an ACE inhibitor. A decrease in the arterial pressure due to autoregulation, or an increase in the sympathetic nervous system because it causes vasoconstriction. So you see, when we give those ACE inhibitors or those angioretention blockers, actually is what they're talking about here. My bad. Okay. Angioretention blockers and ARB. Some of you guys may give them at work. Okay. So someone has high blood pressure, we give the angioretention blocker, then hopefully it can help reduce that blood pressure. You see how the drug can work now based on what we just got done talking about the renin angiotensin aldosterone system? Yes, no, maybe so. How
Yes.
many of you give
Yes.
angioretention
Yes.
blockers? Probably all of you if you're working in a nursing home. If you work in dialysis, all right? So that angioretention blocker is blocking that renin, really, in a sense, because the renin's trying to convert this here. So it's blocking that renin from being able to do that and from being able to increase the pressure. And that hopefully over time stops additional damage to the kidneys. The sympathetic control of the glomerular filtration rate is working at managing that blood pressure over time. Baroreceptors in the body can change rapidly to any changes in the arterial pressure. So whenever those baroreceptors detect that there's a decrease in the blood pressure, okay, it's going to give a signal to increase the sympathetic nerve activity, causing vasoconstriction and decreasing the glomerular filtration rate so we can increase the blood pressure. So the body's always working in some way or another to try to maintain that homeostasis. So again, if we have an increase in the blood pressure, that's going to cause constriction of the afferent arteriole and dilate the efferent arteriole. If we have a decrease in the blood pressure, that'll dilate the afferent arteriole and constrict the efferent one. So this is how the body is controlling that blood pressure. If the blood pressure changes too extreme, the body wouldn't be able to compensate here, not those kidneys anyway. So when you have little changes in the blood pressure, like when you get up from sitting down, okay, why don't you have orthostatic hypotension? Because your body is adjusting for that, these little adjustments there, so that that doesn't happen. But if you notice in some of the older people, they have the hypotension just because of standing up and moving. And part of that is because of the way the kidneys are responding, some of those fluctuations in the vessels because they're damaged, and some of the physiological changes that we see in the elderly. All right. Three physical forces are involved again in that glomerular filtration rate: the glomerular pressure, the colloid pressure, and Bowman's capsule. So that controls hydrostatic pressure. And you know that with hydrostatic pressure, colloid pressure, they all work together based on what's happening there. Where's the most pressure? That's what's going to cause that fluid shift. All right, let's go to some of the problems that we're going to see now. All right, incontinence, this is loss of the voluntary control of the bladder. So if it's from stress, think about it. What's stress? So we're talking about increased pressure on the abdominal area here. So sneezing, coughing, laughing, and this happens usually to people that have multiple pregnancies, okay, or have a weak area there, a weak bladder muscle. Okay, so that can lead to this issue. So with stress, we have increased pressure there and it forces it out. All right, overflow incontinence. This is from an incompetent bladder sphincter. This is more at risk for people that are older because they have a weakened detrusor muscle and it can prevent complete emptying of the bladder, leading to frequent emptying and incontinence. With overflow, the bladder doesn't fully empty here. Enuresis. This is involuntary urination by a child over 4. So this could be because of developmental delay, some sort of sexual trauma, sleep patterns, psychological issues. Retention is the ability to empty the bladder, and sometimes it's accompanied by overflow incontinence. If the client has a spinal cord injury at the sacral level, that blocks that reflex that the body uses in order for you to urinate. And so that can cause them to retain urine or not void at all. And retention can happen after anesthesia, either general or spinal. So sometimes you'll see this in pregnancy. With spinal cord injuries or brain damage, sometimes they end up with a neurogenic bladder. That means it's spastic or flaccid. And this because of damage to the central nervous system. These clients might need an SP tube. When your sympathetic nervous system is at rest, your blood vessels are going to be dilated and autoregulation will occur. But when you're stressed out and that norepinephrine or epinephrine is released, this is going to cause constriction, okay? And it's going to be constricted in those afferent arterioles because remember, the main renal artery is going to the afferent arterioles, and so the body won't be able to filtrate properly. The sympathetic nervous system also stimulates the renin-angiotensin mechanism. A drop in filtration pressure will stimulate the kidneys to release that renin and erythropoietin. Hemodialysis. This is usually required 3 times a week. Each session lasts about 3 to 4 hours. So usually this is happening when the kidneys aren't working. These clients can get infected shunts. Usually they have to use a fistula or a shunt for this. The blood clots can form there. Blood vessels can become sclerosed. A lot of times they'll have to move the site, especially over time. And there's always a risk for infection with Hep B, Hep C, or HIV here. With peritoneal, we usually do that in the home. And they'll use that peritoneal membrane. It takes more time, it's more complicated, and they're at risk for peritonitis. So again, 2 different risk factors there for hemodialysis. They're going to be more at risk for infection, either in the shunt or that fistula. They're more at risk for things like Hep B, Hep C, or HIV. It's done in a facility usually. Now they're actually making machines so they can do it in home. but for the purposes of this test, okay, that's your risk factors there. And then with peritoneal, because that's done in the home and because you're using your own body there as the dialysis portal, okay, it takes more time. And the risk factor there is peritonitis because it's going into that peritoneal membrane right there. What are the symptoms of peritonitis?
The
Rigid abdomen. Okay, what else?
um, is it something to do with the stool, right?
No, it'd be
No.
hypotension and
Oh yeah,
tachycardia,
hypotension.
right?
Okay.
Okay. You guys should know that. So keep trying to remember these terms. You want to know these terms. These are what's going to help you understanding, and it's going to help you later. All right. So both types of dialysis can cause infection. All right. So when we talk about mixturation here, okay, the kidneys are going to be connected to those ureters. So the ureters come down to the bladder. There's peristaltic movement there. The bladder itself is like a balloon. It has smooth muscle. Smooth muscle causes action. All right. So you have that detrusor muscle, which will contract. And that's a reflex that's really involuntarily. Okay. You can voluntarily control it, but it's really an involuntary reaction there. It triggers you and you have to go to the bathroom, right? You run to the bathroom and it comes out. There's pressure, okay, from the volume in there, and there's a long flat segment there. There's also a little triangular area there called the trigome. All right, so on the right, I just put a little slide there that tells you about the different types of incontinence. Okay, so stress is that increased abdominal pressure. Urge is caused by the increase to urinate, even when the bladder isn't full. Overflow is because they have urinary retention, so the bladder is not completely emptying. And then functional is when they can't get to the bathroom on time. So that's because, a broken leg, they can't move quickly, whatever the case. Some things that we might see: urinary tract infections. Lower urinary tract infections would be cystitis and urethritis. I'll talk about those a little bit more in reproductive. But both of them, they'll have pain in the pelvic area. They can cause painful urination, urgency, frequency, nocturia. These clients are going to have things like fever, malaise, and leukocytosis. Pyelonephritis, this is an upper urinary tract infection. I think I have another slide where we'll talk about that as well. And here the urine is going to be cloudy, unusual odor if they have an infection. Okay, not for the pyelonephritis, for the urinary tract infection. Urine is going to be cloudy with an odor. Sometimes it'll have bacteria in it. Sometimes you can see like the little things floating in it. Some common causes of those UTIs are E. coli. So there's different types of E. coli in the body. Some of it's good, some of it's not. And also some E. coli in the body that typically wouldn't harm you will if you're immunosuppressed or you have some other issue. Some people will develop a neurogenic bladder that can happen from spinal cord injuries, Guillain-Barré, after a spinal block. So here they lose the ability to control the urinary sphincter, and it leads to incontinence. Women typically get UTIs more than men because of the shortness of the urethra and the closeness to the anus. Things that usually cause men to have UTIs are prostatic hypertrophy and urinary retention. And then there's some other predisposing factors for kids, like congenital abnormalities like the hypo or the epispadias. And then we also have incontinence, retention of urine, or direct contamination with fecal matter. So all those can lead to these urinary tract infections. I don't know why my slides, it's weird why they show up on here. I don't know why the dialysis is showing up on here. Are you guys seeing that, or you just see the urethritis?
Yeah, we see on dialysis. It say hemodialysis and
I don't know why
peritoneum.
it's showing up on that slide. It's not on that slide, so that's really weird. All right, well, I can't do anything about it, but look at the top of the slide, okay? Urethritis is classified in two categories by gonococcal and nonococcal urethritis. The gonococcal is usually from gonorrhea, all right? And the other one is some other infectious organism, most of the time being chlamydia trachomatis. All right, let me just pause this for a second. I'm going to pause the recording.
Yeah.
All right, so it's either going to be gonococcal here, where it's caused by the gonorrhea, or it's non-gonococcal, which typically is going to be from the chlamydia trachomatis. Usually, with pyelonephritis, you can have one or both kidneys involved here. All right, let me pause this again. I feel like I'm on the wrong thing here. I don't know what happened to my slides. I've been up since 5 o'clock this morning working on this. All right. So again, just remembering that, there's two different types here, and I went over them a couple of times for the urethritis, all right, and the non-gonococcal urethritis. All right, so next is acute pyelonephritis, okay? Here we have one or both kidneys involved, and it affects from the ureter into the kidney. You'll have purulent exudate that will fill up the pelvises, the calyces, and recurrent or chronic infection can cause scar tissue here. It can cause obstruction and hydronephrosis, and eventually renal failure. Some of the symptoms are going to be similar to what we see with cystitis, but you might also have a dull aching pain in the lower back or flank area, a high temperature, and urinary casts might be present there. Next is glomerulonephritis. Usually here, you're going to have the anti-streptococcal antibodies. We have this antigen antibody complex, which is causing deposits here and damage in response to the inflammatory condition in the glomeruli. We'll have increased capillary permeability. So some of the proteins and red blood cells are now going to be where?
In the urine.
In the urine, where they're not supposed to be. All right. You'll have congestion, cell proliferation, decreased glomerular filtration rate. This will cause the body to retain fluid and waste, and they could go into acute renal failure. Symptoms. You should know this from nephrotic syndrome. So urine dark and cloudy, facial and periorbital edema, then generalized, elevated blood pressure, because the body is going to produce renin. Why? Because it recognizes that there's a decrease in flow here. It doesn't care why. Okay? So it just knows that there's a decrease in the blood flow, and so it's going to start to produce that renin and try to increase it. Flank or back pain, stretching of the kidney there, which leads to edema and pain, and then a decrease in urine output. Okay, next is nephrotic syndrome. So here again, you have a problem with the glomerulus, and that's going to cause plasma proteins to go into the urine. So protein in that urine. All right. And this can be because of a few things. Systemic lupus erythematosus, nephrotoxic drugs. So we'll see low albumin levels here, a decrease in the osmotic pressure. That's going to cause edema throughout the body. Low blood pressure. If the angiotensin levels rise, the blood pressure could go up. Increase aldosterone secretion in response to the low blood volume. So this can lead to severe edema. Here, we're going to have blood cholesterol and lipoprotein in the urine, and that's going to give the urine this milky color. So those are your significant differences there. You see them? So massive edema here. The other one is going to be more facial. That lipiduria, or that milky appearance in that urine. The other one's going to be protein of blood. This is going to be protein and that lipiduria, or that milky color. All right. So what else can happen is hydronephrosis. Okay. This is usually caused because of some other issue, tumor, scar tissue, kidney stones, untreated prostate enlargement. It can lead to kidney failure. Okay. So we have hydronephrosis of the kidney, and it's backing up. You see, it can cause distension of the renal pelvis and block the ureter, compression, damage to the vessels there, ischemia. Renal cancer. This is a primary tumor arising from the epithelium. It's going to be seen more often in the cortex of the kidney. It can metastasize to the liver, lung, the bone, or the central nervous system. And a lot of time it is by the time we realize that someone has it. It happens more often in men, especially men that smoke. So what are we going to see? Blood in the urine, but there's no pain there. It's just blood in the urine. Dull, aching flank pain. You can probably palpate the mass there. Unexplained weight loss, anemia, paraneoplastic syndrome. What's that? Who knows? Don't be afraid to say it now, guys. Be afraid on that test. You got to speak it into existence, okay? That's when the tumor is producing hormones, and it can cause you to develop things like Cushing's disease, or syndrome, actually, it would be. Because if we can get the tumor to stop producing the hormones, you should go back to normal. Hypercalcemia, why? What do we talk about with the parathyroid gland?
When phosphorus goes up, calcium goes down.
Okay,
And
so
when
that kidney disease, right, is leading to the increase in that phosphorus. All right, so that parathyroid gland may have a hard time controlling those calcium levels here. All right, bladder cancer. The biggest issues here are those alkaline dyes, the rubber, the aluminum, working with those chemicals, okay? Cigarette smoking. Think about my uncle. My uncle worked for Goodyear Tire, and he died from cancer, okay, from those dyes being exposed to them. Early signs of bladder cancer: blood in the urine, hematuria, dysuria, infection, tumor. Kidney stones. Okay, they can cause manifestations if they obstruct the urine. Sometimes people don't have symptoms right away, or they only have symptoms if they have pain. All right, but it can cause hydronephrosis, dilation of the calluses, atrophy of the kidney tissue, causing the urine to back up. And also, they can have that strong pain, right? That renal colic where the body's trying to reject that stone or get that stone out. Can also lead to hydronephrosis, decrease in renal function, pyelonephritis if it goes untreated. Causes of it are alkaline urine, sometimes eating a vegetarian diet that's high in oxalate. So, like spinach and things like that are high in oxalates. Or if you have hypercalcemia related to a parathyroid tumor, or another thing that would cause hypercalcemia would be multiple myeloma. This is just talking about hydronephrosis again and some of the causes of it. All right. Besides the calculi, tumors, scar tissue, developmental defects, or some sort of kinking or stenosis. So the babies could actually have ultrasound that could show this, that would allow us to fix this before the kidney damage actually develops. If it happens for a long period of time, it can cause necrosis, damage to the vessels, and eventually chronic renal failure. Nephrosclerosis, this is where we have vascular changes like arteriosclerosis. So it can cause thickening, hardening of the arterioles, the small arteries, occlusion. This can cause renal failure. And we're going to see this in people like diabetics, high blood pressure, some people that have some genetic disorders. Polycystic kidney. This is where they develop all these cysts. It's due to that abnormal chromosome 16. And eventually it'll lead to kidney failure. The kidneys will become enlarged, compressed, destroyed. Wilms tumor. This is a rare tumor that can develop. It usually starts from birth. So these babies have the potential for the tumor to grow in the womb, in utero. All right. And then the mass will start to grow. Usually we know it because the waistband on the clothes doesn't fasten, or they have this bulge on one side. Some of these kids will develop high blood pressure. Acute renal failure. What are some of the causes? Bilateral kidney disease, prolonged circulatory shock. So if we have vasoconstriction is what's going to happen in shock, right? So prolonged vasoconstriction is usually how they ask it, is going to cause kidney damage. Anything that's toxic to the kidneys. Okay, myosins never let you win. They're toxic to the kidneys and the urine. So all these drugs that are out there, some of them are toxic. Mechanical
Ms.
obstruction.
Loach,
Yes.
when you say myosins, that's like antibiotics, like
Yep. Like
the okay,
vancomycin, gentamicin.
okay.
Mechanical obstruction. This can be from a kidney stone or tumor. And then chronic renal failure. This is where it's usually not reversible. All right. They might be asymptomatic early on. And this can be from chronic kidney disease, polycystic, low exposure to nephrotoxins over time. Some of your systemic disorders like lupus, because it attacks all the organs. Other ones that can affect it would be diabetes, high blood pressure, a stroke, anything that would affect the blood flow. That nephrosclerosis. And then eventually they end up on end stage renal failure where the kidneys are now not removing the waste. Okay, so that's why it says negligible glomerular filtration rate. The kidneys are not removing enough for them to sustain life. So now we have to have some other way to get that waste out of the body, or they'll develop waste in the blood, azotemia, anemia, and acidosis. So with this, we're going to see a decrease in the GFR, high creatinine levels. The BUN, creatinine and BUN are our main tests for kidney function. So in the beginning, okay, and I would know these signs. In the beginning, you're going to see an increase in the urinary output. Usually they'll have anorexia, nausea, weight loss. And then as time goes on, the urine will start to become less and less. The skin becomes dry and poritic, and that's usually because of the waste, the uremic acid, and things that are in the blood. Neuropathy, impotency, encephalopathy, heart failure. They can't activate the vitamin D. Know what the uremic signs are also. Uremic frost on the skin. Sometimes they like to ask about those. And those are on the cahoots. All right, so know the differences between chronic and acute. What would cause it? All right, everything we just said, really. All right, now we're going to talk about reproductive system. Okay, so you should know what some of the parts are. Okay, mainly like your epididymis. This is where your sperm matures. You know, I call that P. Diddy's house. That's how I remember the sperm matures there. Your vas deferens, that's going to bring the sperm out to the urethra. The prostate gland, the job of the prostate gland is to secrete alkalinity into the semen, okay, so that the sperm can swim and be fertile. Okay, the Cowper's gland, remember, only cowboys have this. Okay, and it's going to secrete that alkalinic fluid to help neutralize the urine, and it also provides lubrication and protection for the sperm. Your urethra, which is going to eject the semen, okay, and it also carries the urine, and then, of course, the penis itself. Male hormones. So you have the follicle stimulating hormone. I call this the fish. Okay, it helps with spermatogenesis and it helps with the development and the swimming of those fish to the site. Okay, so it helps produce those sperm. The luteinizing hormone, I call this the little hoe. This is going to stimulate testosterone production. Okay, so this is waking it up, the little hoe. And then the testosterone allows for the maturation of the sperm, the sex characteristics, the protein metabolism, and the muscle development. Those are the main ones you got to know. For women, okay, we have the mons pubis. This is the tissue in the hair over the symphysis pubis. We have the labia majora and minor. These are the inner and outer folds of skin. The clitoris, this is similar to the penis. It's erectile tissue. The vagina, this is going to be your muscular distensible canal from the vulva to the cervix. Now, women only have the Bartholin glands, and those are going to help produce mucus to lubricate for penetration. The Skene glands, also only female, and those help with the urethromeatus, and they also help secrete mucus to keep everything moist. The uterus is that muscular organ. That's where the ovum that's fertilized can be implanted. The cervix is the opening into the uterus and the neck of the uterus. And the external OS is the opening from the vagina filled with thick mucus. It prevents the vaginal flora from ascending into the uterus. And then you have the internal OS. You have the fallopian tubes. These are from the ovaries to the uterus. The ovaries, which produce the ova, the estrogen, and the progesterone. And then the breasts, which are adipose tissue, and they produce the colostrum and the milk for the newborn. So the menstrual cycles typically between 21 and 45 days in between. It consists of the menstruation process, which is day 1 to day 5. So here the ovum has not been implanted yet. You have endometrial proliferation and production of the estrogen. You have the follicle stimulating hormone produced here, or the fish. So in women, the fish helps mature the ovarian follicle. In men, the fish helps with that spermatogenesis, or the production of that sperm. The maturing follicle will secrete estrogen. That helps with proliferation of the layer of the endometrium. As the luteinizing hormones greatly increase, ovulation will take place and release the mature ovum. So in women, the luteinizing hormone is going to help release that mature ovum. In men, that little hoe is going to stimulate testosterone. Now you have that ovarian follicle converted into the luteinizing hormone in the corpus luteum. This will increase production of progesterone, and progesterone gets the body ready for that ovum to be implanted. All right. It enhances the development of the endometrial blood vessels and the glycogen secreting glands. If fertilization doesn't take place, then the estrogen and progesterone levels will drop. The corpus luteum and the endometrium will degenerate, and menstruation will start. The pituitary gland secretes two important hormones that work together for the reproductive system: the follicle stimulating hormone and the luteinizing hormone. And these hormones are going to signal either the ovaries or the testes, okay, to start the processes that you need to support your reproductive health. So the follicle stimulating hormone affects the function of the ovaries and the testicles. It stimulates the follicles on the ovaries to grow and prepare the eggs for ovulation, and it initiates spermatogenesis in the male for production of sperm. Then the sex organs produce either steroids or hormones, progesterone or testosterone, in response to the luteinizing hormone. In females, the luteinizing hormone causes the release of that mature egg. That is going to stimulate the ovarian production. And this is when you're most likely to get pregnant. It causes the corpus luteum to produce more progesterone, and you need progesterone to support the pregnancy. In the male, the luteinizing hormone, or the little hoe, is released over time, and testosterone is produced at a constant level in response to that. I feel like it jumped up a bunch of slides. Okay. All right. Next is cryptorchidism. This is when the testicles fail to descend into the scrotum. They don't understand why. All right. But it is a high risk for them developing testicular cancer later. This should be fixed by the age of 2. The risk will significantly increase if it's not fixed by the time they're 5. Ectopic testes. This is where the testes is positioned outside of the scrotum and it can cause degeneration of the seminiferous tubules. So remember, they help with that spermatogenesis, and then they help bring the sperm up to that vas deferens so that it can be moved along the way. So if there's damage there, it's going to affect in them being able to produce or reproduce. Torsion of the testes. This is an emergency. This could happen from a hernia or some sort of trauma. The testes rotate on the spermatic cord, compressing the arteries in the veins. It leads to ischemia, scrotal swelling. It could also be spontaneous. Peyronie's. This is where we have fibrous scar tissue on the penis, and it causes a bend or a pain. It can result in painful sex, erectile dysfunction. It's thoughted that repeated injury to the penis is the primary cause. So this could happen during activity, during sexual intercourse, during athletic activities. But there's also some evidence that it might be hereditary with certain connective tissue disorders. It may put them at risk for developing this. Prostatitis. This is usually an ascending infection, so it moves up the bladder along that mucosal wall. Here, acute bacterial gland is tender, swollen, and boggy on palpation, and they will sometimes ask you a question about those symptoms. The urine and the secretions will have bacteria and pus in them. Acute bacterial prostatitis is ascending usually, and usually caused by E. coli. So we might have a UTI caused by E. coli. Maybe they have BPH. They can get this from gonorrhea, from catheterization, or sometimes through the blood from certain infections. In most cases of prostatitis, the urinary tract is infected, and signs of dysuria, painful urination, frequency, urgency occur. Other parts of the reproductive tract, like the epididymis or the testes, could also be involved. Balanitis. This is a fungal infection of the glans penis. This can be transmitted during sexual activity, and it's usually caused by some yeast infection. A lot of times we'll see this in uncircumcised males. So we have Candida albicans as one of the primary causes. It usually appears as the penile vesicles that later develop into patches, cause severe burning and itching. So again, not properly cleansing the foreskin here. And then you have to be careful with the foreskin because it's delicate. So you want to make sure if you are cleaning it or doing anything with it, that you pull it back up, that you never pull it all the way down. BPH. This is a common disorder in men over 65. I would know that fact. Hyperplasia occurs here. We'll have compression sometimes of the urethra and obstruction. It can be because of an imbalance between estrogen and testosterone associated with aging. Usually a rectal exam will reveal the obstruction. There's no connection between BPH and prostate cancer. And if we allow it to continue to obstruct without correcting it, it can lead to hydronephrosis and kidney damage, because a hydronephrosis is going to cause distended bladder, dilated ureters, compression. Signs and symptoms initially would be hesitancy, dribbling, decrease in the force of the stream. The stream might go in all different directions when they urinate, and they may not be able to fully empty the bladder. Urination at night and frequent urination. Cancer of the prostate is going to be more common in men over 50. It's invasive to regional tissues like the lymph nodes, the urethra, and metastatic to the bone. So prostate cancer loves the bone. Tumors will vary in degree of how severe the cancer is. So the more undifferentiated they are, or the more anaplastic, meaning anti don't play, the more aggressive it's going to be and the quicker it's going to spread. Most are adenocarcinomas arising near the surface of the gland. We may use a PSA and a biopsy to confirm. Bone scans for metastasis. Usually they'll have a hard nodule in the periphery of the gland, detected on rectal exam. As the tumor develops, obstruction can occur, and that will also produce hesitancy, decreased stream, urinary frequency, or bladder infections. Most testicular tumors are malignant. Benign tumors of the testes are extremely rare. The majority of tumors are malignant, and they come from the germ cells. So some tumor markers that we might use for testicular cancer are HCG and alpha fetoprotein. Testicular tumors will follow a specific pattern of spreading, usually in the iliac and the para-aortic lymph nodes, and then to the mediastinal and supraclavicular lymph nodes, and then metastasis to the lungs, the liver, the bone, and the brain. This is a condition that typically occurs in age group 15 to 35. I would know that. It's the most common solid tumor cancer in young men. I would know that. And most common cause or predisposing factor is going to be that cryptorchidism or male descendant of the testes. These clients can be infertile, so we're going to have them go to the bank and donate sperm. Because once they get the procedure, the testicle may need to be removed, and they'll probably get a prosthesis there. Tumors are going to be hard, painless, usually on one side only. It can cause the testicle to feel large or heavy. They'll have dull, aching scrotal pain, sometimes pelvic pain. Hydrocele or epididymis can occur here. And gynomastia, or like a budding of the breast, is what they'll look like their breasts are budding if the tumor is secreting different hormones. All right, menstrual abnormalities. So amenorrhea, this is the absence of menstruation, and in order for it to be primary, they could have never had a period before. So usually it's primary if they haven't had a period by the time they're 16. Secondary is going to be from usually some sort of hormone imbalance, or it could be from something like anorexia. Dysmenorrhea, this is painful menstruation, and this can be caused by release of prostaglandins because of endometrial ischemia. It usually happens a few days before the menstrual cycle, and it can last a few days after the onset. We have a few different patterns, okay? So menorrhagia, I call this menorrhags when we bleed all the time, okay? Because this is constant bleeding, increase in the amount and the duration. So that's when you have your cycle. You're going to have this huge amount of flow there, okay? Menorrhagia, this is where we bleed in between the cycles. So I call this metro, between the bus stops, because metro, okay? So it's happening between, you're bleeding between the cycles. So instead of you going 28 days, you go 14 days and bleed, and then another 14 days, you start your cycle, then you go 10 more days and bleed. Polymenorrhea, these are short cycles. Okay, so a lot of cycles. Every 3 weeks, you're having a period. And then oligomenorrhea, where it's a long time in between the cycles. Endometriosis. This is where you have endo, endometrial tissue outside the uterus, the ovaries, the ligaments, or the colon. So it can grow everywhere outside of the uterus. And the problem is that tissue responds the same way as the endometrial lining in your uterus. So whenever your period comes on, okay, you're going to have excessive bleeding because it's not just the endometrial lining that's shedding in your uterus, it's all these other areas where this endometrial tissue has grown. The problem is the blood has no way to get out of the body. So it irritates the tissue because it doesn't belong there. It causes inflammation and pain, and it can cause fibrosis tissue to develop there. It can block the fallopian tube and prevent the ovary from being implanted, and that could lead to infertility. The primary sign of this is going to be painful, period. The pain can persist throughout the menses and typically becomes more severe every month. They might have painful intercourse as well, or dyspareunia, especially if the vagina and the ligaments are affected by the adhesions. Infection of the uterus, the fallopian tubes, and the ovaries. This is pelvic inflammatory disease. So this is considered an infection of the upper female reproductive system. All right. And reason why, because it can infect the uterus, the fallopian tubes, and the ovaries. It can be acute or chronic. It usually starts as an ascending infection in the lower tract. And because of the way the tract runs, it can go right up the tract to these other areas. It can be caused by bacteremia, sexual infections, STDs, non-sterile abortions, childbirth. So we'll see a steady pain that increases with walking, tenderness during the exam. Lower abdominal pain is usually the first sign. The pain could be sudden and severe or gradually increasing in intensity. It can also happen because of infections like appendicitis. Wearing your pants too tight sometimes can cause infections, and those infections can go up and travel up. So if you get a UTI and you don't take care of it, that can spread. All right, next we're going to talk about the breast for a minute. So this is fibrocystic disease where we have nodules or masses in the breast tissue, and this can happen during the menstrual cycle or because of hormone levels fluctuating. The connective tissue is usually replaced by dense fibrous tissue. Increasing fluid in the breast during the secretory phase of the menstrual cycle will accumulate in the cysts, and it's not able to escape. And over time, the cysts will become larger, and it will cause degeneration of some of the normal tissue. For breast cancer, most cases in women occur between the ages of 50 and 69. Usually they're on one side or unilateral. Earlier onset is associated with the more aggressive types. They can come from the ductal epithelial cells or from the lymph nodes. Because, if it starts somewhere else, it can metastasize in the body. Also, if it starts in that talus spence, okay, your lymph nodes are right there. Where's the talus spence? It's in the upper outer quadrant, okay, underneath your armpit. That's where most breast cancers start, are right there. And what's right there is your lymph nodes. So it could start there and metastasize as well. Presence of estrogen or progesterone receptors on the tumor cells will influence treatment. The malignant cells will spread at an early stage, first to nearby lymph nodes. Tumors in the upper outer quadrant and central breast area spread to the axillary lymph nodes. In most cases, several nodes are affected at the time of diagnosis. Widespread dissemination follows quickly, including metastasis to the lungs, the brain, the bone, and the liver. Predisposing factors, first degree relative with it. Strong genetic predisposition, so they'll have the BRCA1 and BRCA2 gene. longer and higher exposure to estrogen. So they may have been taking estrogens for some reason, or they could be postmenopausal and taking estrogen. Nulliparous or late first pregnancy, lack of exercise, smoking, high fat diets, radiation, cancer of the uterus, ovaries, or pancreas. So first, they'll have a single small, hard, painless nodule. Usually the mass is movable in the early stage, but later becomes fixed. And other signs would be dimpling of the skin in the breast, retraction of the nipple or discharge from the nipple, changes in the way that the breast looks. And the biopsy would confirm it. So here you have a primary tumor. It can either go through the lymph nodes or through the vein. And then depending on which way it goes, okay? If it goes to the vein, it'll end up in the vena cava. And from there, it can go to the lymph nodes. This is primary breast cancer, okay? The liver and the ovaries, the brain. Otherwise, it can go into the lymph nodes and it can go down and spread out, okay? Again, to the lungs. And they can develop multiple tumors. Most cases of cervical cancer are caused by HPV. Vaccines now exist to protect us against that. Routine pap smears are important to identify the early stage. The majority of cervical carcinomas come from squamous cell. Biopsy is used to confirm it. Cervical cancer is also strongly linked to STDs like herpes simplex virus. So it's not just HPV, it's also herpes simplex virus too. Usually it's asymptomatic, but it can be detected by the PAP stage. And I mean by the PAP test. And I told you in that that zone, okay, there's a zone there that we talked about on the slide, where that's going to happen at, where you can pull those cells where dysplasia and cells typically gather for cervical cancer. This is the one of the few that can be detected by the PAP test. Some of the other ones cannot. So usually with cervical cancer, they'll have bleeding or spotting, possibly a light watery discharge, and anemia or weight loss. Now, endometrial carcinomas, this is uterine cancer. This can happen in women over 40. Most of them are going to be between 55 and 65. People with high levels of estrogen have a higher incident of uterine cancer. There's also an increased incident in those with obesity or diabetes. Painless vaginal bleeding or spotting is the key sign here because the cancer erodes surface tissues. The pap smear cannot detect this. They'll have to aspirate the uterine cells and do a biopsy. Late signs of malignancy are a palpable mass, discomfort, or pressure in the abdomen, the lower abdomen, after intercourse. These tumors have a poor prognosis and usually metastasize to the lungs by the time we recognize it. They grow slow, but they're very invasive. Okay, ovarian cancer, I call this "oh, bury me" cancer. Most of these people are not going to survive. There's no reliable screening tool. Usually we detect a large mass through a pelvic exam. Only about 25% of the cases are diagnosed in the early stage when the prognosis is favorable. This is considered a silent tumor. It varies in degrees of aggressiveness, but it does use a process called seeding. You'll want to know about this. They'll also talk to you about this on the cancer chapter. So the seeding allows the spread of the cancer in the body fluids along the membranes, and it'll spread all along that large peritoneal membrane, that ovarian cancer, or that "oh, bury me" cancer. Early indications of ovarian cancer include a feeling of bloating, fullness, indigestion, frequent urination, backache, and pain with intercourse. A large mass might be detected by a pelvic exam, but usually they'll be pretty far along if that happens. If you look at the picture here, this is showing you the seeding and how it spreads along that continuous peritoneal membrane. All right, STDs. So this is like chlamydia. It's one of the most common, caused by chlamydia trachomatis. With males, they'll usually develop urethritis and epididymitis. Remember, it's the non-gonococcal urethritis. So they'll have painful urination, itching, white discharge from the penis, pain, swollen scrotum, unilateral. So it usually only affects one side, epididymitis, fever. With females, they're usually asymptomatic until they develop pelvic inflammatory disease or infertility. And these babies that they're having could be affected. If mom has an active infection when the baby's born, they can get it through the birth canal. Viral infections, genital herpes, the gift that keeps on giving. This is caused by HSV2 or 1. You can get HSV1 with oral sex. Lesions are going to be similar to HSV1. And here they'll have outbreaks of blister-like vesicles on the genitalia. Usually before they break out, they'll have some sort of tingling or itching there. The lesions are very painful. And then after the acute stage, the virus goes back to the dorsal root ganglion, where sometimes it will lay dormant. Usually they're more infected, or they can infect people quicker when the symptoms are present. Condylomata acuminata, this is genital warts. It causes HPV. Incubation period can be up to 6 months. This can be asymptomatic. The warts can vary in how they look. They can appear wherever contact with the virus has occurred. They can be removed also, the warts, through different procedures. This can predispose someone to cervical or vulvar cancer. And they're just showing you on the right how those warts look. They usually have a cauliflower-like appearance. Trichomoniasis. This is caused by Trichomonas vaginalis. This is a protozoa infection. And men are usually asymptomatic, but women will have that fishy smell. It can be subclinical. It flares up sometimes when the balance in the vaginal area is off. It causes intense itching, and both parties have to be treated here to get rid of this. All right, now we're on cancer. Any questions about any of that I just went over?
No.
Go ahead. Nope. All right, we got a few more minutes. We'll see what we get through. So know a little bit of this terminology, okay? Differentiation is when cells look alike. If they vary too much, we have a problem. When they're undifferentiated, they're going to be aggressive usually. Mitosis is where we produce two genetically identical daughter cells from a parent cell. This form of cell division is used in growth, tissue repair, and asexual production. Mitosis is part of the cell cycle. So the reason why they're telling you about this is because when we're doing chemo and stuff like that, sometimes we can kill the cancer cells by hitting it during certain phases of the cell cycle. So mitosis being one of them. Mutation is where we have a change in the genetic makeup, and it can be inherited, but it also could be spontaneous. Okay, but if the DNA in the parent cell is altered and passed on, then the offspring is going to carry that mutation. And then apoptosis is that programmed cell death. All right, that neoplasm or that tumor is cell growth that does not respond to the normal genetic controls. So the cells are going to reproduce, and we don't need them to reproduce. They're just reproducing on their own. This deprives other cells in the body of nutrition. It can trap the nutrients for the cancer cells. Okay. So that's why sometimes our patients, we're not feeding them when they have cancer because the body's not getting the nutrients anyway. And you'll notice, like when they're on hospice or whatever, they're just swelling up. Their body can't even use the nutrients. Tumors can be atypical or immature cells. It depends on the tumor as far as what the characteristics will be. But they all have a unique structure and growth pattern. All right. You should know what is the root, so, and what is the suffix. Okay. So, like the suffix, if it's oma, okay, it's going to be benign tumor of fatty tissue, like lipoma is fatty tissue, benign is oma. Okay. So the oma makes it benign. The fatty tissue is the lie. So the lipoma is a tumor of the fatty tissue, and so on and so forth. So you should be able to put these words together because you have to know your medical terminology. This will help you answer some of those questions. So make sure you look at these well and realize and recognize, what does it mean? What does the term mean? Okay. So carcinoma is a malignant tumor. Okay. So adenocarcinoma. And then sarcoma is connective tissue. So fibrous tissue, connective tissue equals fibrosarcoma. This is a malignant tumor of the fibrous tissue. All right, then you know about the cells, okay? Benign tumors are going to be like a normal cell. So it's going to grow like a normal cell. It kind of looks like a normal cell. Abnormal cells or undifferentiated cells don't look like the other cells, and they grow rapidly. They'll also, malignant cells are going to invade other tissues. It can spread through blood, through lymph vessels, and it will destroy tissue and spread tumors. For brain tumors, it doesn't matter if it's benign or malignant, okay? Both of them can be deadly. Why? Anybody know?
Cranial pressure.
Okay, that intracranial pressure and compression on the vessels in the brain. Okay, the brain doesn't have room for anything to grow with it. The bone doesn't move, so there's no place for anything to expand. So if something else starts growing in there, it's only going to put pressure and cause damage. So systemic effects of a malignant tumor are going to be weight loss and cachexia, which is severe malnutrition and muscle breakdown. Anemia, because of the blood loss at the tumor site, and nutritional deficits can cause a reduction in the hemoglobin. Remember, the cancer cells are stealing some of those nutrients. Severe fatigue from the changes in the body, the cachexia, the anemia, psychological issues, and the stress. Effusions, inflammation that can lead to fluid buildup in certain cavities of the body. Infections because the body's resistance to immunity breaks down, especially because if you're under stress, you're going to produce cortisol, and that is going to immunosuppress you. You may be on cortisol as well. Tumor cells can erode the blood vessels and lead to bleeding. And then paraneoplastic syndrome, this is where the tumors are releasing hormones because of the neurological function or effects that they're having on the body. This will happen with certain tumors in particular. All right, so we use tumor markers, biopsy, certain enzymes, antigens, hormones we'll look at, and they can tell us about risk factors. We use the CEA, the carcinoembryonic antigen, for certain cancers like colon cancer, HCG and alpha fetoprotein for the testicular cancer, alpha fetoprotein for the liver cancer. CA-125 for ovarian cancer, and PSA for prostate cancer. We can also screen high-risk people doing a genomic tumor assessment, which looks at genetic mutations that may occur with this person due to other inherited factors. So the tumors, how do they spread? Through invasion. The tumor cells grow into the adjacent tissue, like uterine carcinoma. It's going to invade the vagina. Metastasis is when it spreads to different sites. So it started in the prostate and now it's in the bone. Or it started in the breast, now it's in the lungs. Ovarian cancer, as I said, spreads through seeding. And again, I call this bury me because poor prognosis. They're going to die. And by the time we realize they have the cancer, it's going to be too late to do anything. So you have the primary tumor there, and it spreads through seeding along that peritoneal membrane. And eventually it can metastasize all the way up to the liver and other places. We use a staging process. Okay, T tells us the size of the tumor, N tells us involvement of the lymph nodes, and M tells us about metastasis. So with stage 1, we call that usually in situ. The stage 1 usually isn't moving, it's just sitting there, okay? It's not metastasizing, there's no lymph node involvement, there's no metastasis. It's just sitting there. And it's less than 2 centimeters. In stage 2, the tumor can be as great as 5 centimeters, but no more. And here we're going to have 1 lymph node involved, but no metastasis. In stage 3, the tumor will exceed 5 centimeters, and we can have up to 2 lymph nodes involved. The tumor may be fixed here, but no metastasis. And then stage 4, the tumor could be any size, but it's fixed to the chest wall or the skin. There's at least 3 nodes involved here, and we have metastasis. Carcinogenesis, this is where normal cells are transformed into cancer cells. We believe that cancer is multifactorial because of environmental effects, heredity, infection. All these things can cause it. It's usually not one single thing that causes it. And most of them have well-established risk factors of some sort. I would know this, okay? These are the stages. So first, you have the procarcinogens, and these cause the first irreversible change in the cellular DNA, all right? So this is like your first exposure to the cancerous product. You don't actually create a tumor here. But then you have exposure to promoters like hormones, environmental changes, and those cause more changes in the DNA. So now you have less cells that look alike or less differentiation and an increased rate of that cell reproduction, or the cells aren't dying. Okay. And that's because, again, these cancer cells can grow rapidly. You'll have dysplasia or anaplasia. Okay. So either the cells don't look right or like the other cells, or anaplasia where they're indifferentiated totally. And then eventually you develop the tumor. So if you look on the right at the diagram, first you have this first change, which is an irreversible mutation of the DNA. Then you have repeated exposure. So like the first change could be from that first cigarette. But then you repeatedly smoke, repeatedly smoke, repeatedly smoke. And eventually changes are going to occur to that DNA and other cells there. And then eventually you develop the cancer and it spreads, depending on what kind you have, how much it'll spread or if it will spread. So prognosis, you have to be cancer-free for at least 5 years to be considered survival. Some cancers, like leukemia, can be considered cured after a 10-year period. Remission is when they show no clinical signs of cancer. And sometimes clients will go in and out of remission. And the life and the expectancy and the death rates all vary based on the cancer. Okay. I told y'all my uncle had pancreatic cancer. He was diagnosed in October and dead in December. He didn't even know he had pancreatic cancer because he got sick in July with diabetes. That's one of the first signs, but people don't typically check you for pancreatic cancer because you're over 40, you may be overweight, and now you're having a problem maintaining your blood sugars. So they're just figuring you have type 2 diabetes. Then he started to develop signs a few months later of constipation and stuff. They still didn't catch it that it was cancer. And then by November, they finally realized it was cancer. And by December, he was dead. So, it can happen really fast or it can happen really slow. And you may end up being cured or going into remission for a long period of time. So, malignant tumors, skin cancer. Okay, this is visible, easily diagnosed and treated. It's an excellent prognosis, except for malignant melanoma. That's going to be malignant. Ovarian or ovarian cancer. Okay, poor prognosis because of the hidden nature, high mortality rates. And then brain tumors, both benign and malignant, are life-threatening because of the compression of the brain tissue. Both of them can kill you. Usually they do before anything even serious happens with the tumors because of the pressure that they're creating in the brain. So sometimes people will start to have a seizure or a headache, and that's how we know. Basal cell carcinoma is the most common form of skin cancer. It's usually going to look like this pearly papule with a little ulceration in it. The lesion itself may have itching, but no pain. And it can remain and grow slowly. It's a slow invasive type of tumor into the subcutaneous tissue. The most common cancers for men and women are going to be prostate for men, and then lung and colorectal. Breasts for women, followed by lung and colorectal. Some other terms that you need to know, okay? Allele. This is when we have one or more alternative forms of a gene. Okay, so an allele would be like your mom gave you a blue eye and your dad gave you a brown eye. Typically, that doesn't happen because we usually end up with either blue or brown. Okay, but the allele is that color, the blue or the brown, and depending on whether it's a dominant or a recessive trait on how many we need from our parents in order to get it. So if someone has a dominant gene, that gene can do whatever it wants. It can make your hair red. It can make your hair blonde. Okay, it can make you have a disease. If you have a recessive gene, then usually you need two of them. So if you're going to have blue eyes, you got a blue gene from your mom, a blue gene from your dad. Okay. If you have sickle cell, you can get one cell from your dad that's good and one cell from your mom that's bad, and you could have the trait, but you wouldn't have the disease because it's a recessive disorder. So some of this you guys may not understand yet because we haven't talked about some of it. All right, but I do have a video on this if you want to go on and watch it, I believe. Chromosomes, these are genes that are matched for function. Okay, so you have paired chromosomes throughout the body. You have 23 pairs. Okay, 22 of them are regular chromosomes. The last pair are sex chromosomes. So you give up 23, whoever you marry gives up 23. And together you have 46. A gene is the part of the DNA that acts as the unit of heredity. And each chromosome has a unique set of genes, as well as your pair of chromosomes. Now, heterogeneous means that you got two of the same genes. There are two genes that are like. So, like your mom gave you a blue one and your dad gave you a blue one. I'm sorry, heterogeneous. Let me say that again. Heterogeneous means that you got two different alleles, okay? You got one from your mom and one from your dad, but they're not the same. So, like, you got one brown eye and one blue eye. Homogeneous means you got two identical alleles. So, how I remember this and why didn't I remember it? I don't know, maybe too much talking here today, but homo, okay? When someone's homo, they like the same sex, right? So these are two genes that are exactly alike. If they're homogeneous, they're homo, they're alike. If they're heterogeneous, they're different. So heterogeneous would be like a husband and a wife. They're different. So two different genes is heterogeneous. Two of the same genes is homogeneous. The karyotype is a system that we use. We put all the chromosomes together and we arrange them by size. And that can usually tell us if someone has a problem. Non-disjunction is when we have two chromosomes, okay, and they're supposed to break apart during cell division so that one goes to the daughter cell and one goes to the other, but this doesn't happen. They don't break apart. So this causes an error in the chromosome. This would be like Down syndrome. So they have an extra piece in that chromosome. Trisomy means they have an extra piece. You should only have a pair, but now you have an extra part there. Monosomy X is another one. This is Turner syndrome. And these kind of non-disjunction errors could lead to spontaneous abortions. You also have what we call phenotype. Okay, phenotype is like you have brown hair, and that's what we see. So that's the way it looks to us. That phenotype is your outward presentation. You either have brown hair, you have blonde hair. That's what we see. Translocation is when a piece of the chromosome moves from one part of the chromosome to another. It could be either on that same chromosome or on a different one. And again, these can cause chromosome disorders. All right, so your genetic information is stored in your chromosomes. You have 23 pairs, 22 are autosomes, one pair is sex chromosome. Girls are going to be XX, boys are going to be XY. And the karyotype shows us the arrangement of those chromosomes. And we use this to detect chromosome disorders. Again, of the 23 pairs, 22 are not involved in controlling your gender. They're called autosomes. And then one pair of sex chromosomes controls your gender. During meiosis in the human being, each ovum receives 23 chromosomes, one chromosome from each pair. When the ovum is fertilized by the sperm, then that zygote or that new baby is going to have 46 chromosomes or 23 pairs. And it's going to be an assorted amount of information inherited from your parents, depending on why it's going to you and what is needed to make up your DNA. Females have two X chromosomes, and a male will have an X from mom and a Y from dad. The female gets an X from each parent. Because there's so many different sequences possible, only people that are identical twins will have the same genes and DNA sequence. So DNA is considered a unique identifier, and this is why we can use it to detect certain things. The genes control your physical characteristics like your eye color and even things like color blindness, as well as your metabolic processes. Let's skip the questions. You guys can do those on your own. All right, this is karyotypes. Okay, so when I was talking about the karyotypes and pairing them up and looking for chromosome abnormalities, this is an example of that. A mutation can happen in the genetic material, and the gene could produce a trait that's different from the original trait. Mutations can happen during reproduction, but some of them will cause a serious or a deadly disorder that occur in 3 different forms, either a single gene disorder, a chromosome disorder, or a multifactorial disorder. So dominant genes will dominate any situation, even if only one parent carries the gene. And recessive genes are going to fall back unless both parents have it. If the affected parent passes the altered gene to half of the children, okay, then half of them would be affected. The other half would be normal because they didn't get the affected gene. In autosomal dominant, you need one gene to be given to you from your parent in order for you to see that, in order for you to get that trait or that disease. So if you inherit a certain disease from your parents and it's autodominant, you only need one of your parents to give you that bad trait or that bad gene. Okay. So let's say your father has a copy of a mutated gene for an autosomal dominant condition, but your mom doesn't. You have 2 possibilities to inherit it, each with a 50% chance. You can get the affected gene from your dad as well as one of your mom's unaffected gene, and you'll have the condition. But if your dad gives you the unaffected gene and so does your mom, you won't have the condition and you won't be a carrier. So you only need one of your parents to pass on the autosomal dominant condition. If it's an autosomal dominant condition, you have a 50% chance of inheriting it. If one parent has the affected gene, has 2 affected genes, then you have a 100% chance of being born with it. So if for some reason your dad had 2 of these genes and you were born, you would have a 100% chance. But typically they only have one. Okay. So if they give you one of those autosomal dominant genes, you can get the disease. Autosomal recessive disorders include things like cystic fibrosis, which affect the exocrine glands, the lungs, and the pancreas, sickle cell disease, which involves defective hemoglobin, and PKU, where a metabolic enzyme is missing. In recessive disorders, both parents have to pass on the defective gene to produce an affected or homogeneous child. So homogeneous would mean you got 2 defective genes and they're alike. So that's homogeneous. Those 2 genes are alike. Male and female children are affected equally. If the child is heterogeneous, that means if they get one normal gene and one gene for the disease, then they'll be a carrier and they typically don't have signs of the disease. So sickle cell is a good example of this. All right. So let's say that my dad has sickle cell and my mom doesn't. If my dad gives me one of those sickle cell genes, I'm going to have the trait, but I'm not going to have the disease. Okay. If my mom and my dad both have the trait and they each give me one of those genes, then I'm going to have the disease because it's recessive. So I need 2 of those affected genes in order to have the disease. And this is why sometimes people have sickle cell disease and sometimes they just have the trait. If it's a pregnancy where each parent is heterogeneous, that means they only have one of the genes that are bad, then the child is a carrier and will show no clinical signs. The probability of inheritance is 25% that the child would be born with the unaffected gene because each parent could give them an unaffected gene. 50% chance they'd be born with the carrier genotype because one of the parents could give them the trait by giving them one recessive gene, or 25% that the child would be born with the affected disease, that mom and dad could give them the gene that's affected. And so, because they have two bad genes, that would make them have the disease. Questions on that? For X-link, okay? If mom gives one X chromosome to the offspring, the dad will give an X to the daughter and a Y to the son. The son will carry the X from mom. For recessive traits XX and XY, they'll be affected. More males will be affected. If the male inherits an X-link altered gene, he'll express the condition. So this would be like Duchenne's muscular dystrophy or color blindness, hemophilia. These are X-linked diseases. And because the male only has one X chromosome, when the disease affects him, it's going to affect all the genes on his X chromosome. Okay? Because females inherit two X chromosomes, they could be heterogeneous or homogeneous. So they could receive one good and one bad gene. So they could be either a carrier or have the disease. But typically, we don't see girls with these X-linked, some of these X-linked diseases because they have two X chromosomes. So boys are typically affected by these more. All right, that was the end. And I'm still working. Let me stop this.